Okay, so we're back for a few minutes before our three official 3 p.m. return. I'm here with Nick Hatt, who's going to be giving our next presentation, which is really his reaction to the rules that dropped this week. Nick is a product designer here, and he's part of the early founding team for Redox, so he knows the landscape very well. And the first thing I noticed today when I got on was that he is dressed unusually. I usually don't see Nick in a jacket, and he's got a lanyard on. So I want to know what's on the lanyard, first of all.
So David, this is an official HIMSS 2019 badge. I have a weird thing where I collect my badges from previous years. Yeah, had some time today to dig it out. Just thought it'd be a little nice touch. Remind everybody how fun / terrible it is to be at HIMSS. And yeah, I mean, I never wear a blazer, so also didn't want to miss my one opportunity a year to dig it out and put it on. So here we are.
We did a poll earlier, and a small minority weren't planning on going to HIMSS at all. So fun or not, I think everybody was planning on being there. And I know that this ruling is really top of mind for everyone that would have been there or just works in healthcare in general. So we're all excited to hear you talk about it. And so you spent yesterday reading over what came out?
Yeah, it was a crazy day. We got a nice 2,000+ word blog post out that I'll plug at the end of the presentation, but go ahead and check it out now too if you want to. That's just blog.redoxengine.com. A lot of the rules were not very different from what was in the proposed rule that came out a year ago, the Monday of HIMSS. So yeah, I mean, Jordan in the comments here mentions that it's 1,244 pages, but a lot of that is just sort of the comments that they got, the responses to the comments. The actual rule changes, it's about 83 pages or something like that. So depending on how you read it, you can skip all the way to the end and just see what was changed. And ONC made some really good fact sheets, and the CMS rule was actually pretty light, pretty concise. So I feel I couldn't sleep last night. I was so excited after a day of reading these regs. But yeah, we got a good presentation for you here today.
Excellent. Well, I will post the blog post in the chat at the end of your presentation, and then we will make sure that it's included in the follow-up along with your slides and video from today. So thank you so much for being here, Nick, and take it away.
Awesome. Hi, I'm Nick, and we did a little introduction earlier on, but I work here at Redox. I've been here for 5 years. Software developer most of the time, and I'm also kind of the de facto regulatory guy. So I want to condense this 2,000 pages of documents that came down yesterday into 30 minutes. So we're going to get rolling. We're here right at the top of the hour. 21st century cures is where all this came from. A lot of people don't necessarily know what happened yesterday or why it happened. And this might just be a little civics lesson, but basically December 2016, still the Obama administration, they passed this huge bipartisan bill called the 21st Century Cures Act. So if you're watching the news, you probably hear about things in Title I, which are the Beau Biden cancer moonshot, lots of money for the FDA, things like that. All the way buried down further in Title IV are things that actually affect healthcare IT. And it takes some time for these policies to be implemented. Specifically, Congress writes this law, and it's very abstract, and they sort of delegate a lot of the work to the executive branch, in this case, ONC, the Office of the National Coordinator, and CMS, Center for Medicaid Services. It took them actually until 2019 to sort of write the policy that implemented the first day of HIMSS last year. Kind of crazy conference with a lot of buzz around it. It was a good chance for the ONC people to actually come and to be on panels and stuff and talk about it. But yeah, left a lot of people just kind of frazzled because they were trying to be on their feet all day and then go home and read some really dense documentation. It got a ton of comments. This is the ONC rule. So close to 2,000 comments from individuals, big companies, everyone across the whole healthcare continuum. And yesterday we finally got the final rule. So there's sort of no more changes to this. Came out at around 8:45 a.m. Eastern time yesterday, and there were some signs that it would come out. And there was quite a bit of controversy leading up to it, where Epic notably was sort of wanting to put them on hold to deal with privacy concerns. There was no hold. It did come out. So what actually is in these rules? There's actually two separate rules from two different offices. So make sure you read both if you're into the reading part. The first one is from ONC. ONC's directive is to sort of govern healthcare IT policy broadly. They run the Certified EHR Technology Program, which has been around for almost a decade. And they have sort of full control over how you get certified, what the criteria are, and if Congress asks for something, they put it in. Second, ONC was given a new power by Congress under 21st Century Cures to say what is not information blocking. So Congress very clearly said information blocking is anything that impedes access to data for an authorized party. So that could be a patient, that could be an application vendor who sort of has a contract with the health system, but maybe the EHR vendor is dragging their feet. The overall intent was say, hey, this is bad. This is slowing down innovation. It's hurting patients. But ONC was tasked with a very unenviable task of saying what is not information blocking. So basically, everybody's information blocking unless you're not. And then CMS has a few kind of different levers to pull than ONC. They sponsor certain insurance plans, so Medicare Advantage being a big chunk of that. So they can sort of put requirements on payers to do certain things related to interoperability. And finally, they also get to decide which hospitals are allowed to participate in Medicare payments. So they can use that lever to change things. So they've changed some things there, and we'll get to that towards the end of the presentation. Jumping right into the ONC, the certification criteria is sort of one of the big outcomes of the ruling. There's a lot of boring stuff in there, some house cleaning. For example, NCPDP is what's used for e-prescribing. It's a standard. They just kind of bump the version. So they say, within the next 2 years, you should implement, I think actually they said January 1st of this year, but you just bump the version and a lot of other things. They kind of, there was an audit logging requirement, and they sort of said, okay, it should meet this standard where there was no standard before. They kind of revised standards. The real notable new additions are two criteria. One is EHI export. And if you're a Redox podcast subscriber, you heard Anish talk about this with Nico. This is the one where if you have any data relating to a patient, and let's say you can't export it as FHIR, you can't export it in any known format, you just have to dump it. So like dump it as CSV and give us a link to something that explains the columns. But you have to like produce this full dump. So that's kind of a crazy new uncharted territory for the EHR world. The specific language around it is also kind of troubling if you're an EHR vendor, where it's a patient should have access to this, but a health system should also have access to it for all the patients in case they want to change systems. So essentially, you're dumping every single, your relational database. It's every single column that you can make a foreign key relationship to the patient from. So certainly not a small engineering challenge, and yeah, definitely I get good for competition from sort of the macro level, but we'll see how that actually plays out. There's another new requirement for having a bulk data API. So a lot of the the stuff that's already live today is patient auth, where you go and a patient actually has to physically say, okay, this app can read my records. Bulk data is more of a population level query, where you can say, send to the health system, I want all the patients with this condition, and it gives you back this FHIR bundle. And it's kind of cool. Talk a little bit about the challenges that are going to come with that and the timelines associated with some of these things being actually live in the real world. Another big change to this sort of certification program is what's called the conditions of certification. So it used to be that you would get certified, you sort of go through a laboratory, they test that your functionality meets the requirements, and you get a stamp, you get put in a database on the ONC website, and then providers can use your software to get certain incentives. We'll get to that in a little bit. They added a new thing where you can now sort of be in bigger trouble if you're not doing things the right way. Essentially, to get certified, you have to attest to certain things that are not necessarily certification requirements, but ongoing kind of good citizen things. The first one that's drawn a lot of controversy is that several EHR vendors have these gag clauses in their contracts with their customers. So it says, your employees can't share screenshots of our product. Your employees can't share any kind of, safety concerns. They should all come to us first. Clearly there's arguments on both sides. So if you're sharing screenshots of a product, I think a lot of us live in sort of the SaaS internet software world where that's kind of crazy that you would want to block that. But the EHR vendors have legitimate intellectual property concerns. Essentially, this ruling now says you have to notify your customers if you have one of these gag clauses that you won't enforce it, and then stop putting those in your contracts. It's kind of a huge win for, I see it as a win for providers who are struggling with the usability of their software. You can start to see a world where EHR vendors are sort of usability shamed. It's going to be fun to watch. There's other requirements around APIs. So there's sort of this, I guess you would call it a backlash against marketplaces. So EHR vendors over the last few years have sort of started to build up these marketplaces where they want apps to come in, register, and then take, the EHR vendor takes a cut, sort of a rev share. There's been different models we've seen. Those are now essentially very problematic for the EHR vendor to promote. And specifically when it comes to patient access, the rules are very clear that you have sort of 10 business days to respond to a request, to sort of register an application, and then 5 days to enable it for production use. So there's very tight timelines associated with registering an application. And saying no is a lot harder. So you have to sort of have really good documentation ahead of time of what kind of apps you approve and reject. And I think the idea is that they don't want EHR vendors to use their access to the data as a competitive advantage. So you can't be profiting off the fact that you have all this patient data and taking a cut of app vendor revenues because you're there and you're sort of the big one, or you're sort of holding the keys. And there's also sort of a pushback to more of the healthcare organizations owning that process. So we've seen a lot of centralization with the EHR vendors, where they want to control the app store and they want to sort of be their approvers. The rules say that the APIs should be maintained by the HCOs, or they should have ultimate control over it. There's just sort of a promise that you won't information block. We'll talk about information blocking. But if you are caught information blocking, there's a fine in addition to possibly losing your certification. And one of the interesting things that was left out is there's no TEFCA requirement. So ONC asked for comment on whether or not TEFCA should be sort of connected to this. And ultimately, they thought TEFCA is too new. They're still kind of figuring out how it should work. There are no QHINs yet, so it doesn't really make sense. It's important to remember this is all a voluntary program. So if you're an EHR vendor, You might not be affected by this today because some of these, incentives don't necessarily track your providers or don't track the type of customers you serve. But this is all being very closely tied to value-based care in general. So it used to be called meaningful use, and now essentially any program that has a value component, we're seeing EHR certification play into it. So in the case of MIPS, it's like a point system. So you get certain points for using certified software and doing certain requirements within the software, sharing data. You can make those points up in other ways, but it's really easy to get those things if you pay for the software. So fun to watch. So some of you may be saying, okay, like awesome, finally I can get access to some of this stuff through an API. A lot of the anti-competitive practices are going to be done with. Not quite. Here's a great one of these fact sheets that ONC put out yesterday that kind of outlines the timelines for this stuff. So a lot of the things that are sort of policy based start today, but there's these clocks that start running. So if you look at the gag clause, that starts today or yesterday. I think the vendors have a week or a month or something to notify their customers that they won't enforce the gag clauses. But you have to go all the way out to 2022 for these APIs to be officially rolled out. So there's a two-year window where the EHR vendor is expected to do development and then certification. And then if there's sort of an on-premise solution or however they deploy to their customers, get that software rolled out. And that EHI export, where it's kind of the whole dump of CSV or whatever format you want, that's actually given a 3-year window to implement, because it's, like I said, it's a huge engineering challenge. And it sort of scale, it's even harder with the size of your system or the number of tables you have or columns you have. And yeah, it will be a while before you can actually use this stuff. But it's important to contrast that with the fact that Epic, Cerner, and the big EHR vendors already have this functionality in place for some aspects. So all of the patient auth stuff, you can do Fire, you can do Smart on Fire. The version of Fire that is in the rules now is R4, so some vendors need to upgrade. But yeah, it's going to be kind of a chaotic next 2 years, where you're going to have a lot of systems ahead of the curve and a lot of systems behind the curve. CMS also released a rule. I alluded to this in the beginning of the presentation. The main thing here is that CMS has leverage over certain payers who provide federally sponsored plans, and they I'm blanking. They want to make the same patient authorized API ecosystem work for everyone who's getting insurance coverage through these plans. So Blue Button is a good example, where they provided a Fire API, and it works a lot like Smart on Fire. The timelines are pretty aggressive for this one, and it'll be interesting to watch and see how that plays out. And again, it's restricted to the plans that the government offers, but there's sort of an inkling that maybe it will be rolled out to maybe more members, or that maybe more regulation is coming to kind of push it over the hump, so more people have access to this stuff rather than just Medicare beneficiaries. There's another requirement to have payer-to-payer exchange. And this is a cool one, where the idea is that if you're on one plan and you switch to another plan, it makes sense to have that data transport to the new plan. The specific standard is not called out, and they kind of say, hey, it would be cool if patient auth worked for this. But yeah, time will tell. They have kind of 2 years to implement it, so we'll see what the consensus is. It could just be flat file transfers. Again, CMS is a little more just visionary and not as specific with requirements, but yeah. There's other kind of smaller things, so standing up provider directories using FHIR. You can see where that's kind of cool. So in plans offer provider directories today, but they might not necessarily be in FHIR. They're kind of different proprietary formats. So you can see tools that help people shop for doctors better, see what kind of things are in network. Yeah, finally, the conditions of participation I mentioned earlier. That's sort of a hard line where you can't get Medicare dollars unless you sort of do certain things. A lot of the current conditions of participation are related to cleanliness and how you run the facility. They have now added this technical requirement to send ADT, so that's sort of a Redox patient admin message, to some regional partner. So you could be a long-term acute care facility, and you want to send notifications that someone who was just discharged from the hospital has arrived, or maybe you're at the big community hospital, you want to send an ADT, you want to send a notification that a patient showed up at the emergency room to their primary care doctor. So yeah, this is kind of, again, pretty nebulous. They picked HL7 version 2 as the standard though, which is kind of interesting given the FHIR mandates and the ONC rules. And yeah, this is going to be one that's going to be interesting to watch roll out, and see. There's sort of an exception in there for vendors who can't support ADT, which is kind of crazy to think. But yeah, it's sort of a very ambitious public health type of goal. Next up, information blocking has sort of been a thread through this whole thing. And it is very separate from all of the other ones because the enforcement mechanism is different. Again, the certification program is voluntary. There's some very harsh things in there. It's not necessarily really voluntary if you can't sell your product without it. But information blocking pertains to certified technology vendors, providers, and then a combination of HIE and HIN, which you can think of as the traditional regional HIE, Commonwealth, Care Quality, those types of organizations. They have certain obligations to provide access to data and not discriminate against people who want to connect. And the enforcement mechanism is actually investigation by the Office of the Inspector General and up to $1 million fine per instance of data blocking. So there's a lot of great examples in the rules. If you want to kind of do a deep dive and see if anything fits, something you might be worried about or something you might have experienced in the past. The classic, example is patient goes to their doctor and says, "Hey, give me my records," and it takes forever. Maybe they give it to you on a DVD, and nobody even has a DVD drive in their computer anymore. A lot of these things are kind of the spirit of the law, and they don't necessarily go into that DVD use case in the rules, but there are a lot of explanatory, examples and how they would expect OIG to rule. It's worth going through the exceptions just so people get a general concept of what the rules look like. So there are 8 exceptions to information blocking, and this is sort of very, very broad. So you might say, oh, well, nobody's information blocking, but you do have to provide a lot of documentation for each one of these. The first one is around preventing harm. So if you have some reason to believe that sharing information with another party would cause harm to a patient, you can say, no, we won't share that. This one, is a little controversial because does it mean that you should not share any information at all? Or, are there certain pieces that you can censor and still not be information blocking? So it is, there are some gray areas, but yeah, I think this one, in principle, you can't really disagree with. The second one is also very, non-controversial. HIPAA is still the law. So I can't just walk up to a health system and say, hey, give me Nico Skavaski's medical records. He's my boss. I want to see what he's been up to. That's not the way information blocking works. That's actually the kind of information blocking that needs to happen. And that's sort of the idea of the privacy exception. Security is another one. So the emphasis, again, here is really on the written portion of it. So you need to have organizational security policies that say why certain information can't be shared before you say no. It's, it's hard to imagine this, but let's say an app comes to a health system and says, we want to use your APIs, but we can't do HTTPS. Well, okay. It's okay to say, no, you can't access the APIs because you're not using encryption. And that you would have that written as a security policy somewhere. Like, that's a very low-hanging fruit security policy, but you get the point. There is an infeasibility exception, and this one is also, one of those more controversial, nebulous gray area ones. The spirit of HIPAA is that you can get your information in any format you want. If I go to my doctor though and I say, I want this note you wrote in classical Chinese, they can say, okay, well, we'll give it to you in English. How about that? So you don't get full reign over what format it's in, or sort of what can be done to it before it gets to you. You can't say, I want this map to fire, version 5. There's no fire version 5 yet, but you get the idea. When the law says R4, there's sort of a reasonable expectation that you provide some flexibility, but yeah, also that there's a burden to doing this. Cool. So that's the first 4. I only broke this up on 2 slides because there's 8 of them. Performance is an interesting one. So you can deny access to an application for essentially keeping the system up for everyone else. So there's a few good examples in the rules where if an application is doing something malicious or unintentionally DDoSing you, you can take them offline for the sake of preserving the system. This also has language that protects the vendor from doing, you can take a scheduled downtime, for example, to say upgrade the system. That sometimes that's just unavoidable. And as long as you have it written ahead of time and you sort of have these policies documented, these are all okay. In the final rule, we got a new exception in the content and manner exception. And this is kind of a really interesting one. Something that a lot of the EHR vendors lobbied for. The EHR Association, EHRA, specifically, this is like their headline thing, that information blocking should only pertain to this set of data. It's called USCDI. So this was another part of the rules, sort of codifying USCDI. What we got was 24 months sort of protection, where information blocking only applies to USCDI, and then after that, it's sort of fair game for anything. This one's a really interesting overlap with that full export rule, where you have 3 years to implement the full export, but after 2 years, you have to sort of say, respond to information blocking related requests around all data. And then manner, this was kind of related to my classical Chinese thing. You can sort of have documentation ahead of time to document what manners you're able to express the data in. The last 2 are sort of not that controversial. You can charge some fees to connect to the API and make a profit. They actually included this profit word in the final rule. The the key is that it's transparent and it's consistent across the board. So if a potential competitor wants to connect to you, you can't charge them any different from someone who's, augmenting your product or making your product easier to use. And same goes for sort of licensing the product. You can make money licensing it as long as it's reasonable. You don't price out competitors. So yeah, these two will be interesting. There are certainly vendors out there who are doing things that are not in the spirit of the rules, and we'll kind of see if these get investigated at all, or how serious they're taken. Okay, so yeah, we're almost at the end here, but I just want to give my opinion. So the landscape that they've designed, it already pretty much exists. Project Argonaut and what a lot of the large vendors, especially Epic and Cerner, have done is what is now in the rules. So essentially the rules just make everyone else come along with those groups. Patient auth as this idea has been around for 5+ years. It's been in the rules. ONC, for better or for worse, didn't pick a standard at that time. So they said, you have to do patient auth, you have to have portals. Portals are actually 10 years old, but no FHIR, no Smart on FHIR. Now it's saying after 2 years, you have to have FHIR R4 and Smart on FHIR. The big problems that are still there are still there. So there's this huge fragmentation problem where there's sort of 200 vendors on that certified EHR list, 200 plus. Implementing FHIR R4 is not the same everywhere, so you can have a lot of variation, and even OAuth and Smart on FHIR, there's variations, and you can sort of, one thing we deal with a lot is refresh tokens. So some people expire refresh tokens. Some people's refresh tokens are good forever. Some people's refresh tokens are good for who knows. There's no real-time sort of requirements in any of this. It's all about exposing FHIR APIs, and it's not guaranteed how up-to-date the data will be. Ideally, it's hitting the production system and giving you real-time data, but might not be. There's also sort of not a lot of stuff in the rules for people who need data that's not in US CDI. So anyone who does, appointment scheduling, a lot of the specialties are not in US CDI. It's sort of the core vital signs, problems, meds, allergies, those types of things, the Redox clinical summary, so to speak. And yeah, at Redox, we're sort of in a great spot to help you navigate this new world. A lot of the new integration methods we covered earlier on, the bulk FHIR we support today, and patient auth is something that's nearing an open beta. So please reach out if patient auth, and especially Smart on FHIR, is something that works for your sort of data needs. That's something we're interested in scaling up. Very excited to see that come out. And last September, we announced that if you have a connection that uses FHIR, and if it's limited to that US CDI set of resources, there's no connection fee. So if you're a Redox customer and you have a connection like that, we don't charge you that. We don't consume a connection to do that. It's so easy that we're happy to just throw it in. So definitely bring us those. Like I said, that that 2-year window means that we haven't seen very many of those connections come our way, but we're totally just kind of chomping at the bit because we have all that code written, and it's very easy and seamless. Finally, yeah, we're right at time, but what to look out for. TEFCA was left out of the rules, so just watch for how TEFCA evolves. It could either be a blessing or a curse. So no real lever to join TEFCA, but they might need time to develop. Again, that information blocking being constrained to US CDI is huge. It's likely to kind of come up over the next 2 years, and I imagine people will push back on it being sort of applying to everything. Finally, yeah, what will happen with information blocking enforcement? Will we see huge fines being levied? Will we see people being taken to task for things they've done? Time will tell. And real quick, I'll plug the Redox podcast. This is a great one I mentioned with Anish. he gives great analogies for all this rulemaking. And before it even came out, he was very much, on point with his analogies. And our Redox blog has tons of great content. This is a series we did a year ago, but we have a brand new one I mentioned that's huge from yesterday. And